I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist at McMaster University, and I'm absolutely delighted to welcome Professor Douglas Mann, Lewin Chair and Professor of Medicine at Washington University School of Medicine. Welcome, Dr. Mann.
Thank you so very much, Harriette.
We are live at ACC 2021, where Dr. Mann presented his late-breaking clinical trial, the LIFE trial, that tested the efficacy of sacubitril valsartan versus valsartan in patients with advanced heart failure and reduced ejection fraction. And I say efficacy, but really it was a test on the reduction of NT-proBNP, so a surrogate outcome. Dr. Mann, why don't you tell us a bit about the background that led up to this particular trial?
As many people are aware, the landmark paradigm heart failure trial showed a significant and striking effect on morbidity and mortality in patients with heart failure with a reduced ejection fraction. And I think our entire community was extremely excited by the findings. However, they only studied less than 1% of the patients in that large study actually had advanced heart failure, New York Heart Association Class 4 heart failure. In general, this is a very difficult, fragile patient population to take care of. And so the goal and rationale for the LIFE trial was really to try to see about the safety, tolerability, and potential efficacy of this remarkable new class of drug in a group of patients who remain extremely vulnerable and for whom transplant and left ventricular assist device or hospice are really the best outcomes. So the goal and the hope was we'd be able to extend the use of this particular class of drugs to patients with far advanced heart failure.
Can you tell us a little bit about your eligibility criteria? How did you define advanced heart failure?
So when we started out, we wanted to only recruit New York Heart Association Class 4 heart failure. And we rapidly realized it doesn't exist in the world today in 2021. The doctors are so good about treating patients who are short of breath at rest. Either they get better or they go on to a transplant or a left ventricular assist device. So where we landed was New York Heart Association Class 4 symptomatology within the past 3 months on guideline-directed medical therapy. Ejection fraction had to be less than 35%. And then there were some NT-proBNP or BNP requirements above a certain level. And then one additional finding of severe heart failure, such as being on inotropes within the past 7 days. But it was a pretty sick group of people that we recruited. One of the unique parts of the study is that we did allow patients on ambulatory inotropes to be in the study, which most studies exclude those patients specifically.
Right, so you had an open label run-in phase, and then you randomized patients to sacubitril valsartan or valsartan. Tell us about your primary endpoint and what your main findings were.
Right, so the primary endpoint was the change in the area under the curve for NT-proBNP relative to baseline studied over 24 weeks. That's a mouthful. We wanted to choose a surrogate endpoint for several reasons. First of all, I don't think anybody would have funded a morbidity mortality trial for New York Heart Class 4, which the FDA had already given approval for this. The guidelines hadn't embraced it, but the FDA had already approved Class 4. So we chose change in NT-proBNP for several reasons. One, it's been very accurate in terms of predicting outcomes. Two, in the Paradigm HF study, it had tracked outcomes. Those people who did well dropped their NT-proBNPs. Those who didn't do well didn't drop their NT-proBNP. It's a reliable surrogate for hemodynamic unloading as well as decongestion. So we thought that it was a reasonable surrogate endpoint and allowed us to complete a study with a reasonable study size of about 400 patients was the original study size. So we looked at the change in the area under the curve, in addition to which we knew we needed to get some safety and tolerability endpoints. So in terms of efficacy, we had a clinical composite of days alive out of the hospital and free from heart failure events, which we defined as being re-hospitalized, getting a transplant, a VAD, or going on continuous inotropes. So there was a secondary endpoint of days alive and free, out of hospital and free from heart failure events. And then in terms of tolerability, we looked at the number of people who could tolerate study drug in both arms, hypotension, worsening renal function, and then hyperkalemia. And then we had a series of tertiary endpoints, which are the traditional Kaplan-Meier type analysis of CV death and heart failure hospitalization. In terms of the primary endpoint, the thing that was striking to us and took a while to understand is that when we looked at the areas under the curve for both Valsartan and for sacubitril Valsartan, they really didn't decrease. And this was completely different than had been seen in the other trials. So when one looks at the area under the curve for both groups, there was a very small decrease in the sacubitril Valsartan arm, but it wasn't statistically significant. It was p less than 0.45. But the important point is that neither treatment group really lowered the NT-proBNPs. And this led us to the final conclusion, which is that in end-stage heart failure, we think the renin-angiotensin system tends to override the natriuretic peptide system, which is why we didn't see differences. In terms of the secondary endpoints, days alive and out of the hospital favored Valsartan by just a small amount, not statistically significant. No difference in the amount of study drug tolerated, no difference in hypotension or worsening renal function. There was, however, a small but statistically significant increase in the amount of hyperkalemia in the sacubitril Valsartan arm. Where it got, I guess, really interesting and perplexing was when we looked at the traditional endpoints of CV death or heart failure hospitalization. Every single endpoint favored treatment with Valsartan over sacubitril Valsartan. There were about a 30% relative rate increase in CV death and heart failure hospitalization, about a 20% increase in heart failure hospitalization. No matter how one looked at any of the tertiary endpoints, they all favored treatment with Valsartan. So at the end of the day, we didn't meet the primary endpoint, we can say, and we were powered for that. I also need to mention briefly that because the trial was ongoing with COVID, we decided to shut the trial down early so that none of the hospitalizations would have been impacted by COVID. We were really concerned about patient safety and that the results may have been contaminated. So final study size went from 400, where we had an 88% power on the primary, down to 79% power for the 335 patients. So minimal effect on overall power for the primary endpoint. Nonetheless, we didn't meet it. Secondary endpoints didn't show a benefit for sacubitril Valsartan, and none of the tertiary endpoints did. So in a group of people that's extremely vulnerable, we don't think that there's any significant benefit to using a drug like sacubitril Valsartan as compared to something simple like Valsartan.
Important findings, of course, because we generalize results from prior trials to patients with advanced heart failure. How do you put the results of your trial in context with findings from the PIONEER trial of hospitalized patients with HFrEF?
Right. So PIONEER won a different patient population. They did have class 4 heart failure patients in there, but I think it was 10-15%. It wasn't a significant portion of the patients that they had. And I think the reason that they saw decreases in NT-proBNP there was it's primarily acting, they were seeing a lot of decongestion after being hospitalized for heart failure, for acute heart failure. Whereas in our trial, our patients were extremely well treated to begin with in terms of furosemide use and diuretic use. So I think that there are two different patient populations. One was more acute heart failure, in whom decongestion is the primary strategy. And our trial, which is stable class 3 to 4 heart failure, who are already well decongested, who are already on maximal doses of diuretic just by virtue of the fact that they're in transplant centers and being cared for by people who manage advanced heart failure. So two different really patient populations, I think. Pioneer also didn't show any mortality benefit. All it showed was a decreased NT-proBNP.
Right, and both studies weren't designed in terms of sample size to test the effect on clinical outcomes, but
Right.
absolutely right. I think the findings are somewhat different, but in terms of the clinical endpoints, no significant benefit seen. I will thank you for the generosity of your time this morning. Congratulations on a brilliant presentation. I'm so happy to have met you, and I hope we get to connect again.
As do I, and thank you for your coverage of the trial. And I want to just also close by thanking all the investigators. This was an incredibly hard study to do, and there weren't too many places in the world that could have done this because of the advanced nature. And so we really had a talented group of investigators to whom I'm infinitely grateful. So thank you.
Wonderful.
Bye.
Bye now.